And welcome back to Conceptual OBG. Dr. Aditya here, who's back again with yet another YouTube live session. So, after the last few successful sessions, they have been fairly successful. We have gotten almost 2,000 viewers on them. This month, it was decided that we'll do a session on a topic that has been requested by many people. And this topic is very important, not just from your postgraduate point of view, from your exam point of view, but also for undergraduates who are going to be watching this with us. Now, when I'm talking about today's topic, which happens to be pelvic organ prolapse, it is an important topic not just for your theory exams because you get a lot of LAQs or what we also call as the long answer questions, but it is also important from the point of view of your practical exams because this happens to be one of the commonest practical questions that you get in your or your practical cases that you get in your exams. If you're an undergraduate, you'll be getting it probably in the form of a card, a gynec card. And if you're a postgraduate student, you'll be getting this in your exams as a full long case. And hence, this topic assumes a lot of significance. A lot of people get confused between various surgeries, and the sources, the literature is limited on a few sub segments, I would say, of this topic. And everything that I'm going to be discussing today will cover all of the literature that I have studied till date, all the latest guidelines, all the latest editions of books. If you're going to be asking me what are my sources for today, they are going to be first of all Teeland Book of Gynecology, the latest edition, then Berek and Novak, which I believe is the best thing that has happened to me for gynae, and a few other research publications by Dr. Virkud and a few other practical books as well. So it's a cumulative effort that I have put in from all the books that I have read till now, and I hope the next hour or two are going to help you all understand this topic to perfection. So, without further ado, let us begin. So, when I talk about pelvic anatomy, I am going to be showing you a lot of images today. But before I show those images to you, I also want to make sure that you understand how I see it as a person or how I see it as a surgeon. Now, one more thing, you have learned this topic, the pelvic anatomy or the pelvis, during two phases of your career. The first was your first MBBS, when you learned all the anatomy of the perineum and the pelvic floor and all the pelvic organs. And the next time you read it was in your final MBBS, when it was time for you to learn gynecology. Now, there's a significant difference, and this line has been quoted even in the tail end, and a lot of surgical books quote this line, that the surgical anatomy is quite different from the anatomy that you learn, the dissection anatomy that you learn in your first year, the cadaveric anatomy. The reason is that the cadaver undergoes several processes to preserve the body and to be able to preserve it for our dissection. The process, one of the processes that is called as embalming, puts in a lot of weight in your internal organs and especially on your pelvic floor. Now, because of this pelvic floor weighing down, the pelvic floor starts weighing down because of all this embalming process, and hence the anatomy that you study in a cadaver is not the same which you will be studying or which you will be seeing intraoperatively whenever you operate a female for her prolapse. So today I'm going to be teaching you what is the surgical anatomy and not the anatomy that you have learned earlier that happens to be dissection anatomy. And hence the finer intricacies are going to be lesser because I do not need to know each and every single muscle fiber. I need to know them grossly. I need to know the planes between them and more or less the parts that help me make those planes. So let us begin from the way I see it. So the most basic diagram that I make is going to be wherein I am going to be showing you all a sagittal section of my body wherein I've made a section like this. You're going to be seeing a female's pelvis in a sagittal plane. So when I see it in the sagittal plane, if this is my anterior and this is my posterior, anteriorly I have my pubic symphysis and posteriorly you have your sacrum. Now, between them, you have several organs. What are those several organs? First of all, you have your urinary bladder and your urethra. Next, you have your uterus. And lastly, you have your rectum, which opens up as the anus. So over here, first of all, I have drawn three openings. It happens to be my urethra, my vagina, and my anus. Now, these three organs are lying from anterior to posterior inside my pelvis. But if they are just lying there, when a person is moving, walking, sleeping, lying down, or just jumping around, these organs will start moving. And that is going to lead to instability. Now, instability is never a good thing to happen to any organ in the body. It has to be statically placed for it to be stable in the body. And hence, that staticness or that stagnancy is lended to it by something that I call as the endopelvic fascia. This thing that you are seeing is my endopelvic fascia. This endopelvic fascia is what I call as the cotton of your pelvis. Now, how do I assume it as? Imagine that you have, whenever you order some electronic item from an online site or whenever you get that box, there are those bubble wraps that are kept inside it so that the object doesn't move. Or the other example is whenever you get a box of some perishable or very soft fruits like mangoes, they keep that hay, that dried grass in between them so that they don't crash against each other. So if you're going to remove that bubble wrap or if you're going to remove that hay, in that scenario, these mangoes or the electronic item is going to crash against its box or beat on each other. Mangoes, the fruits are going to crash against each other, and that is going to lead to depression on them. That is going to basically lead to damage to them. And hence, they can even the box can just open out and the mangoes can fall out. So basically, there is going to be instability. This instability is prevented by this endopelvic connective tissue. There is an area where I'll just add a color. There is also an area wherein there is going to be condensation, wherein this cotton wool like thing is going to have thickening. This endopelvic fascia is going to be condensed. That condensation is called as this condensation that I have just drawn. I have drawn it with yellow only because it is a thickening of my endopelvic tissue is called as the uterosacral ligament. Your uterosacral ligament is nothing but thickened cotton wool. So basically, the cotton wool which was lying freely is made tighter, it is compressed, it is condensed in that area, in that region, which makes it attached to the sacrum. So if I'm going to see it superiorly, if I'm going to take a cross section of the body, it is going to look like this. This was my pelvis. This was my uterus, this was my rectum, and this was my urethra. So this is going to look like this, the uterosacral ligament. This happens to be the support that also pulls you can see this angle, this anti-version and anti-flexion is also maintained because this uterosacral ligament is pulling the cervix and the lower uterine segment or the isthmus of the uterus posteriorly. And this angulation is very important. I'll tell you why later. But this angulation pulls it behind, and hence the normal axis of my vagina becomes posterior. So if this is my vagina, the normal axis is facing posteriorly and upwards. So up and posterior. Very important that my vagina is facing this way and not just vertically. Hence, very important. I'll tell you why later, but you have to remember these important things. There's another condensation of the endopelvic fascia that is with the lateral pelvic wall, and that happens to be the cardinal ligament. This is my cardinal ligament to the lateral pelvic wall. And these together are called as, they are not easily separable. They are in fact just one single thing that we also call as the uterosacral cardinal ligament complex. It's a complex which is cumulative, which is a combination of both the ligaments, and we call it the uterosacral cardinal ligament. This transverse thing is the cardinal ligament, and this posterior thing is the uterosacral ligament. Very important basic thing that you all need to know. Now there is a catch to it. This endopelvic tissue and also the uterosacral ligaments eventually have one small problem. The problem is that it contains estrogen receptors. Now, whenever there are estrogen receptors in anything, remember that in a female's body, the estrogen receptors are going to go completely devoid of estrogen. So whenever my body is producing estrogen, that is until my menopause, until 50, 55 years of age, this endopelvic tissue is going to be there in abundance. But once my body's estrogen starts going down because of menopause, there is nothing to bind to those receptors in the endopelvic fascia. Basically, the nutrition of the endopelvic fascia, that was the estrogen, starts reducing. And this reduction is going to start depleting it. This endopelvic fascia is going to start getting thinner. The moment it starts getting thinner, these organs will again start getting unstable, and they are going to move upwards, downwards, anteriorly, posteriorly, and that is going to be one of the main causes of your endopelvic connective tissue failure, eventually resulting in pelvic organ prolapse. So now the problem, that first problem that we studied that leads to your pelvic organ prolapse, happens to be your menopause. One of the risk factors is that you often see these women are peri or post-menopausal women who have an estrogen deficit, who come to you with pelvic organ prolapse. The most common women who have vaginal prolapse, uterovaginal prolapse, turn out to be women in their elderly years, like 60, 70, 80-year-old women. This is the reason why that happens. The other reasons why this may happen is because of the injuries that can happen to this endopelvic tissue. It's a cotton. If you pull a cotton apart, it is going to get torn apart. So what are those factors that lead to that tear? It can be a vaginal delivery. It can be an obstructed vaginal delivery. Basically, there was so much of stress on the cervix and on the vagina, that because of the stressing, because of the pushing away of this endopelvic fascia, this particularly this endopelvic fascia over here, the one anterior and posterior to the vagina, because of the stretching and continuous contractions and relaxation, it led to tears in it. So multiple vaginal deliveries are going to sustain more tears in the endopelvic fascia. Hence, multiparity is one of the risk factors. Obstructed labor, home deliveries are another factor. And all these reasons turn out to be risk factors for pelvic organ prolapse because of the damage that is sustained to this endopelvic connective tissue. And hence, this is one of the most important level of support for your uterus and vagina. It also happens to be the level 2 support of the Dale-Ansi classification. I'll tell about it in the next segment. Very, very important for you to understand this basic thing. I hope everyone has understood this. If anyone has any doubt, put it in your comments. I am reading all the comments. I'll be answering them on your YouTube comment section. So this was a basic overview that I gave you of the endopelvic fascia. But remember that not all women after menopause come to me with prolapse. Everyone is having an estrogen deficit, then technically everyone should have prolapse, but not everyone gets a prolapse. Also, this endopelvic connective tissue contains collagen. So if it contains collagen, women with connective tissue disorders like Marfan syndrome, Ehlers-Danlos, even they should be having a prolapse in a much earlier age, in a younger age possible. And a lot of women have multiparity. A lot of women deliver 2 to 3 children vaginally, but not all of them have prolapse. What is the reason? So apparently, this endopelvic connective tissue is not the only one that matters. There has to be some other level of support as well to augment it, to help it, because these are all my major structures, and just one cotton-like thing is not going to be enough to be able to sustain it. And that is what the pelvic flow is useful for. So my next segment is going to be on your pelvic flow or your pelvic support. So what are my pelvic supports? So when I talk about my pelvic supports, my baseline is going to start by me mentioning that there is something called as a perineal membrane. There is a perineal membrane. I'll just draw on this. And everything is on the basis of this perineal membrane. And you see that it has a slight dome-like, inverted dome-like structure. It is not a flat transverse line. It has a little bit of dome-like structure, inverted dome-like structure. So this perineal membrane forms a main basis for all the ligaments and all the muscles for them to rest on it. So above it, I have something called as my deep perineal pouch. Whereas below it, I have something called as a superficial perineal pouch. Which muscles lie in it, everything I'm going to be discussing about it through next pictures. And just above the deep perineal pouch, I have something called as, I've drawn it with red, and this red is my levator ani. levator ani, or what a few people also call as the pelvic diaphragm when I combine it with yet another muscle. Everything I'll be showing you through pictures, but this happens to be a very basic imaging of the section of my sagittal section of my pelvis. Between all this is my endopelvic connective tissue that I have spoken about. So between all this lies my endopelvic connective tissue. So this is going to be my endopelvic connective tissue, which helps me support the pelvis. Now there is very important one aspect that I need to see, that there are holes that I've made in this levator ani. What are those holes for? So these holes that you can see, the first hole is going to be for the urethra, the second is going to be for the vagina, and the third is going to be for the anus. So this levator ani has three holes in it, and those three holes are the ones that are going to be very important, because they are the ones for my vagina to go out, for my urethra to go out, and for my anus to go out. So now I'll be showing you a few images, and just to extend it, this is my bladder with my urethra, this is my uterus, and this is my rectum. Still see that there is an angle that I have made over here. This angle is very important. I will tell you all why. But before that, we'll study a few images. So now, here we can see this few images. Now in this image, this first image that you can see, I'll enlarge this image a bit for you. Okay. So in this image, you can see that there is this white structure that you can see. This white structure, I'll just draw it with a yellow color. You could see this white structure inside that you can see. This one. Similarly, you can also see it over here, which is just lying below that one. So this white structure that you can see over here is called as the perineal membrane. It is that perineal membrane which I had drawn first up, and uske upar I had made my deep perineal pouch and my superficial perineal pouch. This is that baseline membrane. Now just towards me, or if I'm going to be, this is a female who's lying in front of me, I am doing a, let's say, episiotomy or some vaginal surgery, then just towards me, so between the perineal membrane and towards me lies the superficial perineal pouch. And what are the contents of that superficial perineal pouch? Let us see over here. So the contents of the superficial perineal pouch, there are two important ones. The first one is going to be this muscle that I can see, that is my bulbospongiosus. Very important. Secondly, there is going to be ischiocavernosus that lies laterally, this one. So I have two muscles that I've spoken about, and then transversely is one of the muscles. You can see this one. This is the transverse perineal muscle, or also what we call as the superficial transverse perineum. So these are the three major muscles that form my superficial perineal space or superficial perineal pouch. So over here, as you can see, the various muscles. Now this is without me having dissected anything off with the nervous supply. Over here you have my transverse perineal muscle, ischiocavernosus, and bulbospongiosus. So these three muscles typically form my superficial perineal pouch. I remove all of them. I then see the perineal membrane and I peel it off as well. Once I peel it off, I am now going to expose my deep perineal pouch. So the structures that lie inside my deep perineal pouch include So this is my deep perineal pouch. Now there was the membrane that was lying over here. This was the membrane that was lying over it. But now I have removed this perineal membrane. So once this perineal membrane has been removed, this is going to be my internal structure. So what are the internal structures that I have? There are two major muscles that are inside. The first one is the ureterovaginal sphincter, or the internal urethral sphincter. There is also the compressor urethrae, and lastly, this muscle. You see, this muscle is very similar to what we had seen outside as the superficial transverse perineum. This instead is called as the deep transverse perineum because it is lying inside the deep perineal pouch. Apart from that, I can see a few other muscles posteriorly. These few muscles are going to be the levator ani. If I'm going to see the structure more clearly, you can see over here, this is the levator ani that you can see the pelvic floor. So what form the levator ani or the pelvic diaphragm? I have a few muscles. The first one is the pubococcygeus that is extending from my pubic bone. You see over here, from my pubic bone from here, it is extending and it is going posteriorly towards my coccyx. So pubococcygeus. So basically, if this was my pubic symphysis and this was my sacrum, and if this was my uterus, this muscle I'm showing in green was pulling it posteriorly. So basically, this muscle is pulling me posteriorly, my levator ani is pulling me posteriorly, and this ensures that my angle of anti-flexion and anti-version is ensured. Now, what is the use of this angle of anti-flexion and anti-version? Now, whenever there is any stress factor in your abdomen, like you start coughing or you are straining, that increases the abdominal pressure. So whenever the abdominal pressure increases, what happens is, because of this posterior pulling, this angle comes and reduces even further. So it looks something like this. This angle reduces even further. The advantage is that if it would have been a straight structure like this, whenever pressure came in, whenever I coughed, whenever I sneezed, or whenever I tried straining down, or maybe after a vaginal delivery, if there was a straight pressure through the holes in the perineal membrane and also in the levator ani, the uterus would directly come out or the bladder would directly come out. But this angle ensures that it flexes and it sticks on the vagina. You have your membrane that goes through here, this region. And this ensures that instead of prolapsing completely, it folds upon itself and prolapse is protected, it is prevented. This is the advantage of every single muscle or every single tissue ligament that is pulling the uterus posteriorly at its cervix and isthmus. It includes your uterosacral ligament, which I already showed is pulling you posteriorly. It includes your levator ani. It includes your muscle from the levator ani, that is your pubococcygeus. The main point is to pull it behind so that whenever there is any stress, it is going to fold upon itself. It is not going to directly come down. If it would have been vertical, it would have come down. And hence, this is also called as a diaphragm, perineal diaphragm or pelvic diaphragm. The reason being, pelvic diaphragm is that it forms a diaphragm that prevents anything from going above or down below it. It is just like my abdominal diaphragm, wherein my lungs cannot come down and my liver and stomach doesn't go up. The same way, this pelvic diaphragm prevents these organs from falling down by making them fold upon it. Very, very important, your levator ani and pelvic muscle. So, they are all arranged in a specific order, and this specific order was given by Delancey, and he called it levels of support of the uterus and vagina. So, what were those levels of support? So, he said they are all divided in three levels. So the first level includes your uterosacral cardinal ligament complex. This happens to be your first layer. In the second layer, you have your endopelvic fascia, the yellow thing that I told. And in the third one, you have the superficial transverse perineum and the deep transverse perineum. And the levator ani supports all the three structures or all the three levels. So basically, these are the three levels of support that you have. These were given by Delancey, called as the Delancey's levels of support. Very important, although surgically you may not need to know it as much, but these are the three levels of support that are very, very important. Also remember that all these perineal membrane and everything are attached to this bony structure laterally. This lateral bony structure. The levator ani, the perineal membrane, the uterosacrals, everything is attached to a bone. This helps it being completely torn off and is not just relying on the central soft tissues, because if it would have been attached to only a soft tissue, it would have been very mobile, it would have been easily unstable. But to give it stability and to pull it, to keep it anchored to something, these lateral attachments on your bones are very important. Remember that very clearly. And this explains all the levels of support and the reason it is the vagina and the uterus are all directed posteriorly. So this was about the levels of support of the uterus. So now that we have spoken about it, what are the reasons why these levels of support can undergo damage? So what are the risk factors for pelvic floor damage? Because eventually, if there is damage, these are going to come down, these organs are going to just start coming down, which is going to lead to pelvic organ prolapse. So the first one that we already spoke of is age. With increasing age, female is going to undergo menopause, and estrogen deficit is going to weaken my level 2 support, that is my endopelvic fascia, and also my level 1 support, that is my uterosacral pardinal ligament complex. The next one is what we have again spoken, parity, that is increasing parity, multiparity, and also vaginal deliveries. Next, if there is any chronic stressor that is leading to continuous stress on this pelvic diaphragm at some point, if there is some reason that is leading to continuous abdominal increased pressure, increased stress, these tissues are eventually going to start getting torn off. Example can be COPD because of chronic coughing. This female or this person is going to have continuous coughing, or if a person is chronically constipated, going to strain completely, that straining is going to increase, not only it is going to damage this pelvic floor, the endopelvic fascia is also going to be torn off, but also remember those holes that are shown you in the levator ani, those holes are going to start becoming bigger and bigger. More so when there is multiparity, the hole of the vagina keeps getting bigger for the baby's head to come down, and that increase in the hole is going to lead to a damage, or basically is going to weaken the pelvic floor support of the levator ani, and hence multiparity and stressors are an important risk factor. Apart from that, obesity is an important reason. Why? Because whenever there is obesity, your pressure on the pelvic floor increases, because your pelvic, not just your visceral fat increases, but also your central obesity increases. Because of that fat accumulation, there is continuous pressure of the fat plus the organs on the pelvic floor. This leads to pressure atrophy, and also there is a nerve to levator ani that travels on the levator ani. Because of the pressure on the nerve, it leads to blockage of your vasa nervosum. Vasa nervosum is the vessel that supplies any nerve. So the nerve or the vessel that is supplying the nerve to levator ani is going to get compressed. That will lead to ischemia of your nerve. And if there is ischemia of the nerve, the stimulation of the muscle is going to be reduced. And whenever there is reduced stimulation of any muscle, that is going to lead to disuse atrophy, or basically the muscle is not going to be able to contract the way it should be contracting. That also leads to damage to your pelvic floor. Hence, obesity a very important risk factor because of the compression effects on the pelvic floor and its nerve. So this is all about the various pressures and the various reasons why a pelvic floor can weaken and eventually give rise to the topic for today, that is going to be pelvic organ prolapse. And that is where we start our today's topic. Fine. So now that we have spoken about all this, what are the various types of prolapse that I can have? For that, I'm going to make a very simplistic structure. Normally, I know that my uterus is shaped like this, my vagina and uterus are shaped like this, but for the sake of simplicity, I'm going to draw it this way just to be able to explain it better. Just to be able to explain it better, I'm going to draw it this way. So now this is again a sagittal section, and in that sagittal section, sagittal is basically like this. I have anteriorly my bladder and posteriorly my rectum. Now, this is my anterior, this is my posterior, this is my superior, and this is niche my inferior. Now, if I'm going to look exclusively at this part, just look at this part. This is my vagina. Just look at this part. I'll isolate this part. Now, by the way, there is one more structure that I have to mention over here. You have your peritoneum. This forms your UV fold, that is your utero-vesical fold. It comes here, it goes down deep, and it forms a cul-de-sac, or what we also call as the pouch of Douglas. So this is your pouch of Douglas. Also, this is your endopelvic fascia that I've already spoken of. This particular fascia has also gotten a special name, by the way, what we call as the Denon-Villiers fascia. This between the rectum and the vagina, whereas this and this is together called as the pubo-cervical fascia. Anyway, so now I'm going to only focus on this vagina. Now this is my vagina that I've drawn there. This is my anterior, this is my posterior, this is my superior, or what we also call as the apex. Because it is like the apex of the triangle. So now what are the possibilities that things can go wrong at? First thing that can go wrong is if my bladder is coming too close and is pressing upon my anterior wall and is coming down, which I will call as the cystocele. So basically my anterior vaginal wall is being compressed because of the lack of endopelvic tissue, because of all the risk factors that I've spoken, and that is coming down, what I also call as a cystocele. It can also happen that my urethra is pressing down the lower anterior vaginal wall and is leading to something called as a urethrocele. Very likely problems of the anterior compartment. Or it can happen that posteriorly my rectum is pushing down because of thinning of the Denon-Villiers fascia, what I will also call as the rectocele, which happens to be my posterior compartment failure. Or my uterus that is supposed to be here, I've just not drawn it, is coming down because of the loss of pelvic floor support. Or this used to be my pouch of Douglas. That pouch of Douglas has come down too much because of loss of Denon-Villiers fascia, and inside it I have my intestinal loops, what I also call as the enterocele. And this is my proper UV prolapse, uterovaginal prolapse, or uterine descent, whatever you want to call it, which happens to be my apical component. So I have three components: apical component or apical compartment, anterior compartment, and posterior compartment. In apical, I have uterine descent or enterocele. If a female has already had a hysterectomy done, she doesn't have a uterus and only has a vaginal vault, and now that vaginal vault is coming down, we can also have a vaginal vault prolapse. Basically, 20 years ago, it was a 60-year-old woman back then who had a hysterectomy, but now her supports that were given during that surgery also failed, and at the age of 80, she has come back to me with vaginal vault prolapse. That can happen. So those are both apical failure ka subtypes. In anterior, I can have cystocele or urethrocele, and in posterior, I can have rectocele. Note that I have not mentioned enterocele in posterior compartment failure because it is a type of apical failure. Remember that it is coming from the apex and not posteriorly. Remember that very well. Enterocele repair is done as an apical compartment repair and not as a posterior compartment repair. You can do nothing about enterocele by repairing the posterior compartment. Remember that very clearly. So these are the three types of compartments that I have and the compartment failures that can give rise to pelvic organ prolapse. Any one of these, if were to happen, it is going to be called as pelvic organ prolapse. So an exclusive cystocele is also pelvic organ prolapse, An exclusive enterocele is also pelvic organ prolapse. An exclusive urethrocele is also pelvic organ prolapse. An exclusive rectocele is also pelvic organ prolapse. And an exclusive uterovaginal descent is also your pelvic organ prolapse. Remember that it is not necessary for your uterus to come down for you to call it pelvic organ prolapse, because you have three pelvic organs and not just one. All three of them, if they are coming down, they are going to be called as prolapse, pelvic organ prolapse. To show you an image of the same, so I've gotten an image. Yeah. So now this is your normal pelvic anatomy. You can see that this is angulated posteriorly. I'll make a black pen. You see this is posteriorly angulated. This is the angle that I've been speaking of, this posterior, which is your anti-flexion and anti-version angle. So yeah, this is your posterior angulation. This is a normal anatomy. You have your rectum over here. You have your vagina over here. You have your bladder over here, urinary bladder, and this is your urethra. This is your vagina over here. This is your normal anatomy, and this is your pouch of Douglas. Now, whenever these are going to go wrong, you start seeing them. How are they going wrong? This is containing your enterocele. These are your intestines. So this becomes your enterocele. Here you see how the rectum is coming down from the posterior vaginal wall. Compare these two images. If you're going to compare them, you will realize how it is looking like differently. Yes, you can see now this was a normal rectum, whereas now this is a rectum that has come out from the posterior vaginal wall, which has resulted in a rectocele. And over here, similarly, this bladder was in its normal form over here, but now it has come out through the anterior vaginal wall and is called as the cystocele. So this is how your prolapses are going to look like. And also, this uterus has also come down. You can see that the uterus was in its normal position, but when this is coming down, this is also a uterine prolapse. And that is how your images are going to look like whenever you get any sort of pelvic organ prolapse. The reason is that the tissue in between them has thinned out completely, leading to this failure of the support. How do I quantify it? How do I know how bad is the prolapse? And how do I know when do I start operating, or do I not operate and just give a conservative management? So we have had a few scientists or obstetricians or gynecologists, whatever you want to call them, who have given a few classifications or gradings of prolapse. So the first one that came in gave the simplest classification. He was Jeffcott. So Jeffcott said that I am only going to give you three types of prolapse or three grades of prolapse. So he said, I'm going to have a first degree, second degree, and a third degree prolapse. He said that I'm going to give you only three types. So in first type, he said that the descent is going to be at the level of your introitus. That is, your introitus is basically the opening of your vagina. So he said that grade 1 prolapse is going to be just till the level of introitus. Grade 2 prolapse, he said, is going to be where the cervix or the pelvic organs go outside the introitus. And grade 3 was procedentia, wherein the entire uterus has come out, and it is not just the vagina or a part of the uterus that is coming out. Jeffcott said this is the simplest classification that you can have, but we realized that it is very inadequate. So the next one that came in was Shaw's classification, which we use even today. Shaw said that I'll not keep it as 3, I'll keep it as 4. So first degree, second degree, third degree, and fourth degree. In first, he said that it is prolapse above the level of introitus. Second is at the level of introitus. Third is below the level of introitus. And fourth is complete procedentia. What is procedentia? Procedentia is, if this is my vagina, then my entire uterus has come out like this. My entire uterus has come outside the level of the introitus. This is called as procedentia. Whereas a normal prolapse will have the uterus that is inside and my other parts that are coming outside. So my grade 3 is going to look like this. Like this. So basically this was my introitus. My uterus is still inside, but my cervix, this is my cervix, has come outside. the level, but my uterus is still inside. This would have been grade 3. Grade 2 would have been everything is inside the grade 2 would have been at the level of introitus, so at this level, and grade 1 would have been above this level. This was Shaw's classification. But the problem again with Shaw's classification was that it was only talking about the uterus. It was not talking about the other pelvic organ prolapses. So technically, this was a classification for only uterovaginal prolapse and not for pelvic organ prolapse. So there was someone else who said that let me make it a little better, and that little better is going to be I'm going to keep it the way it is by Shaw. It is just that I'm going to define which type of prolapse it is, and that happened to be Baden-Walker. He said I'll retain the 4 grades that Shaw has mentioned, but I will give 6 locations for it. So he said the 6 locations are going to be, sabse pehle, I am going to have either a urethral prolapse, which we now call as the urethrocoele, or it can be the vesicle, that is my bladder prolapse, that we call as the cystocoele, or it can be my uterine prolapse, or it can be my cul-de-sac, that is pouch of Douglas, that is my enterocoele, or it can be my rectal prolapse, or it can be my perineal body. What is perineal body? Perineal body is basically the condensation of all the muscles that we have spoken: superficial transverse perineum, deep transverse perineum, bulbocavernosus, and levator ani. They all come together between the vagina and the rectum to form a common mass where they all are implanted. They are all attached there. So weakness of it is going to lead to perineal body laxity. We'll study about it later. But these were the classifications. He said that under all these, you can give those 4 grades that Shaw had given: first, second, third, and fourth. So he said, I am going to give you the anatomical location. Uske hisab se tum ek ek ko de do. So it can be grade 2 vesical prolapse with grade 3 uterine descent, with grade 2 POD, that is your enterocoele, with again grade 3 rectocoele. So he basically said that you can give a grading for each one of them. This was the Baden-Walker classification. Someone else again came. He said that Baden-Walker जैसे ही मैं कुछ और करता हूँ, parallel classification बनाता हूँ. That was my Malpass classification. In that he said that rather than making it so complex, I would not want to keep urethra and vesicle separate. I would just call it anterior wall prolapse, or I would call it uterovaginal prolapse, or I would call it posterior wall prolapse, or I would call it vault prolapse. Malpass classification not used much. Everyone was very happy using the Baden-Walker classification until there was one problem. It was not reproducible. I mean, imagine that a person has grade 3 prolapse wherein it is coming outside the introitus, but there is a problem. I do not know how much outside the introitus. There are 2 females who are posted for a surgery of vaginal hysterectomy today, and both have varying grades of grade 3 prolapse. One has 2 centimeters outside, one has 5 centimeters outside. I needed a way of making it objective and not just subjective. What is objective? Basically, if I am sitting here in Mumbai and there is my colleague who's sitting in Delhi, and I want to inform him or her about what surgery I'm going to be doing, and I just tell her grade 3, he or she is going to ask me, how bad is it though? How bad of grade 3 is it? At that point, we decided that there has to be some way that I can tell them how bad is that particular grade of prolapse. And for that, we came up with the latest, that happens to be POPQ classification. Pelvic organ prolapse quantification. Quantification is basically, we literally measure in centimeters how bad is the prolapse, so that it can not only be reproduced, it can not only be conveyed to some other, but it can even be used for research publication. Research publication, if I'm going to publish a certain data, it will not only be able to keep every single person who's reading that article, they'll be able to understand it, but it is also going to help me keep a track of how has the post-operative outcome been. If I'm giving a female a pessary for her prolapse, then I can see if it has actually helped her, if her grade has reduced, and hence pelvic organ prolapse quantification or POPQ classification is a separate, very complex classification. All PGs need to know it. I'm not going to be discussing it today in detail. The reason being that there is already a lecture on Conceptual platform by Dr. Raina Chawla, where she has taught this classification. In this, there were 5 main grades of prolapse. Everything is given in that lecture. I'm not going to be dwelling on it. It is very similar to this one only. In that, the first grade is basically it is coming to level 1 centimeter above the hymen. The next level is between 1 centimeter plus minus of the hymen. The next one is more than 1 centimeter outside of the hymen. And the last one is complete prolapse that is equal to the total vaginal length. It is very complex. I'm not going to be talking about it in this lecture because this lecture is more so about the interventions that we will do. But this was the POPQ classification. And once this POPQ classification came in, now was our turn to start managing this patient. So how do we manage this patient? So now talking about the management, my management is going to have many, what do I say, pillars of decision, wherein I'll have to make decisions on various fronts to be able to decide which is the best surgery for her. And the first thing that I'm going to go for is not going to be a surgery. There are alternative methods of preventing a surgery or a female undergoing a surgery, although they are not greatly successful because your pelvic organ prolapse has occurred because of an anatomical defect or defect on your pelvic floor. And that really cannot be helped by any non-surgical method. But you can prevent that stage from occurring. You can prevent that pelvic organ prolapse from occurring by doing a few preventive measures. Or if it is in an early stage, if it is something like stage 1 or stage 2 of your Shaw's classification, you can in that scenario do a few things to prevent it from becoming worse, because stage 1 and stage 2 is not going to cause as much stress for the female as a higher grade prolapse will. So what are those methods? First of all, in our country, there is a very low awareness that I would say for what we say is postnatal pelvic care. Now, for every female who has delivered vaginally, or not even vaginally, for any female who has been pregnant, remember that there was a significant stress on the pelvic floor to keep that baby, which was a 2.5, 3.5 kgs within. That stress increased even more when it had to deliver that hole, which was so small, was forced to become of the diameter or the circumference as the fetal head. So these are all significant stress factors on the pelvic floor. But the good part is that it's a muscle, and just like people go to the gym to bulk up their muscles and to increase the tone or better them, similarly, your pelvic floor also gives you an opportunity in the puerperal period and in your postpartum complete period for you to make it recover. But the awareness is quite low on this, and a lot of women, in fact, most of the women, I would say, in our country do not opt for that, or they do not even have an awareness of what will happen if they don't do it. They realize it several years, several decades down the line, that the fact that they didn't do all those things that should have been done is now resulting in them having a pelvic organ prolapse and an eventual hysterectomy. So those things are called as the conservative management. And your conservative management is suitable for not just prevention, but also for low grade prolapse correction. This is called as the Kegel's exercise. Kegel's exercises are basically exercises wherein you contract your pelvic musculature in a certain way and then relax it. It is very similar to how you build your other muscles of the body, be it your rectus abdominis, your biceps, your triceps, anything. Anything that you build is based on increasing the weight bearing capacity of them and by making them contract against an increasing amount of pressure that is applied. So in the same way, there are various Kegel exercises, and these are aptly taught by physiotherapists. They have a lot of ways and a lot of various instruments which they use for improving the tone that has been defected because of pregnancy and vaginal delivery. They do, or they go a long way in preventing it. And hence, I would always recommend that in your family, if you have any female who has just delivered, always make sure, irrespective of whether she has had a cesarean section or not, always make sure. A lot of people feel after cesarean section, if they're going to do these exercises after 6 weeks, then it can lead to a rupture in the uterine scar. No, it doesn't. It doesn't even affect it, which is why you wait for 6 weeks and you then start doing it. If you have a vaginal delivery, you can start doing it within a week or two, in fact. So it is completely safe, and do not worry about your scar getting dehiscent or something. Nothing like that is going to happen. Make sure you follow it religiously, do it for 6 months to 8 months, and that is going to significantly improve your pelvic floor tone, and you will reap the benefits of that several years down the line. So it is not going to be something immediate, but several years down the line. So that is one thing. The other way that I can correct it is going to be by using a pessary. A pessary is basically like this. This is called as a ring pessary. There are various forms of pessaries that we have available. So this is a ring pessary. What we do is we calculate the size of pessary. How do you calculate it? So what we do is we insert our hand inside the vagina like this, and then we try to reach out with this tip of middle finger. We try to reach out to the sacral promontory. Once we have reached the sacral promontory, this part is going to be touching the inferior side of my pubic symphysis, and this is going to touch my sacral promontory. So this happens to be my diagonal diameter or diagonal conjugate that you have read in obstetrics. From that point, you have to subtract 1.5 and then you get the obstetric conjugate. Obviously, you do not use these words in our topic of pelvic organ prolapse, but that is how you calculate it. So after you reduce 1.5 from it, you measure this distance and you reduce 1.5 and that is your size. But this is a rough estimate. So you have to give the female a size that is above that and a size below that. And hence you have to give her 3 sizes and she has to be asked to wear that size and to see which size is the most comfortable and the one that doesn't get expelled by itself. Something that is too tight is going to lead to vaginal erosions and that can lead to fistula. Too loose will keep on getting expelled. So you have to give it a trial. And once the ideal size is found out, there is a proper follow-up that is required. That female has to remove that pessary from her body every week at least twice, dip it in a solution of betadine or Savlon, clean it with proper tap water or at least distilled water, whatever she has, and then she has to put it back inside her. Remember, if she doesn't do it, that is going to in fact lead to more vaginal infections and that can be deadly. You do not want that. And we have had patients who have forgotten to remove their pessaries which were inserted 20-30 years ago, and the vaginal mucosa grew on it and the pessary was taken up by the vagina and it had become completely hardened. It had become fixated in the fornices. So to remove it, we had to literally give an incision on the vaginal mucosa and we had to pull it out. We had to cut the the pessary and we had to slowly completely extract it out. So remember, you cannot be forgetting it. It is something that has to be removed every week at least twice. And that is how pessary is going to help. The work of pessary is basically to strengthen the hole that had become larger, the hole in the levator ani that had become larger, and to reduce its length. But the basis is that that hole should be able to support that pessary there and not let it fall off. If the grade of prolapse is so much that your complete failure of your all the supports has occurred, like in grade 3 or grade 4 prolapse, your pessary is not going to work. In them, we shall have all these surgical options. So in surgical options, the biggest dilemma that I have to have has to be between if I have to preserve her fertility or I do not have to preserve. Fertility not desirable. So most obviously, your women who are wanting to desire fertility are going to be young females. Whereas these women are usually going to be middle to older women. But then you would think, why should a young female have any sort of prolapse? So remember, there are several reasons to it. Now, there is a point that I had mentioned when I was discussing the endopelvic connective tissue, that it is made up of collagen. And anything that is made up of collagen is going to be susceptible to connective tissue disorders like Ehlers-Danlos or Marfan syndrome. Very important point is this one. So if a female is having something like Marfan syndrome, then remember that her endopelvic connective tissue is going to be very poor. It is going to be defective. Your uterosacral ligaments are going to be defective. Your cervix, which is made up of connective tissue and smooth muscles, that is going to be defective. So all of this is going to be completely lax. Your uterus is going to come down. Your cervix is going to get elongated because it is not able to stay in its position because the collagen is of poor quality, and that will lead to prolapse in a young female. But this is not a common thing. Connective tissue disorders, though they are autosomal dominant in nature, they are not that common. Then why otherwise would you have young female with prolapse? Remember that if a female has conceived at an earlier age, if she has been pregnant at let's say 20, 21 years of age, which is in fact very common in India, in that scenario, after a first pregnancy, and more so if she didn't come to the hospital, it was a home delivery, which still happens in a lot of, let alone rural areas, even in our cities, in places like Mumbai, it happens very commonly. If it was an unattended delivery, and why do I say unattended delivery? Because there was no trained personnel like an obstetrician who was around. So those people, those untrained, unskilled people who encourage labor at home and who are not trained in doing that, they make the female bear down quite early. What do I mean by bearing down early? Bearing down is a process that a female is forcibly trying to push outside should only begin when the female is in second stage of labor. That is when the cervix is fully dilated. But if a female is going to start pushing before the cervix is fully dilated, it is going to lead to a problem that the cervix, which is not completely dilated, is being forced to completely dilate by the pushing, by the voluntary pushing of the female. A lot of untrained women, not professional, untrained women who are encouraging labor at home, it is most often the in-laws and the elderly women. They even give fundal pressure, and they don't realize that the baby is not coming down because of something like, let's say, CPD, or maybe the cervix is not fully dilated. In that scenario, if they're going to be pushing it down, the cervix, which was usually this much in length, keeps getting stretched. Why is it getting stretched? Because it's not fully dilated. It had to become completely dilated, but वो complete dilation नहीं था, इतना ही था, and then it was getting pushed completely. And because of this, if this, I'm showing you a coronal section, an anterior view. If this was your uterus and if this was your cervix, let us assume that this was your posterior going uterosacral ligament. This is your right, this is your left. I'm seeing it anteroposteriorly. So these ligaments, these uterosacral cardinal ligament complex, they are roughly, or basically, I would say, what do I say? I would say they are unofficially divided into two halves. Unofficially, I would say. Not official, there is no clear demarcation. So the upper half and the lower half. So what happens? The baby that is coming down is now at this level, and the baby is not coming down. And these women are being asked to bear down. Even it can happen in a proper labor ward of a hospital wherein a resident, because he or she wants to end her duty quickly, he is asking or she is asking to bear down, to make the female bear down quickly, or she has started the female on an oxytocin drip and she has literally given it at a fast rate and is forcibly pushing the baby out. What happens is that this cervix is not fully dilated, and because of the incomplete dilatation, this region, this cervix is going to get stretched. When this gets stretched, this lower half of this uterosacral ligament is also going to get pulled. And when it gets pulled out, it keeps getting thinner and thinner. So when it keeps getting thinner and thinner, because of the stretching, this is going to lead to tears in this endopelvic fascia, and that leads to weakening of the lower half of the uterosacral ligaments, and that leads to uterocervical prolapse, but more classically your cervical elongation. Why? Because the upper segment is still in its place, it is not affected, but the lower is affected. So the upper segment is keeping the uterus in its original location, but the cervix has gotten elongated. So a normal uterus, which was supposed to look like this, has now started looking like this. This is called as cervical elongation. One of the causes, as I mentioned, is Ehlers-Danlos or any connective tissue disorder, because the cervix is made up of collagen plus smooth muscles, and the other one is obstetric cause, the one that I just mentioned. This can also happen in obstructed labor, wherein you are not giving a decision for cesarean section sooner if you don't diagnose this early, and you keep giving the female a trial of labor, especially when she has obstructed labor and you do not notice it. Or if there is premature bearing down, if oxytocin has been given at a fast rate, if you're giving fundal pressure at an undilated cervix, these are the complications that can happen. That is cervical elongation. But if it's a female who has some connective tissue disorder, like the one that I just spoke, it won't just be cervical elongation. Even the upper fibers are going to fail, because this entire thing is made up of connective tissue, and the entire uterus is also going to come down. That connective tissue disorder usually leads to uterovaginal descent plus cervical elongation. So when I talk about a young female, now that we have started talking about young women, let us just discuss on then young women with pelvic organ prolapse, they can have two types. They can have uterovaginal prolapse, the uterus and the vagina has come down, or they have cervical elongation, or they have both of them. Now I have to decide on a surgery for each one of these. So if it is just the uterus that has come down and the cervical length is normal, how do I differentiate between uterovaginal prolapse wherein the entire uterus has come down versus a cervical elongation? How do I differentiate? I'll be inserting a uterine sound. A uterine sound is going to give me the UCL, that is my uterocervical length, between 2.5 to 3 inches, which is normal. My uterocervical length is going to be normal in the place where there is only uterovaginal prolapse. Whereas in cervical elongation, my uterocervical length is going to increase, especially my cervical length is going to increase significantly. The length between the internal os and the external os is going to increase significantly. So my uterine sound is a very important instrument to be able to determine whether it is cervical elongation or uterovaginal prolapse. Now, when I'm talking about uterovaginal prolapse, the surgery that I shall be doing is a sling surgery. What is a sling surgery? I'll be just pulling the uterus up and putting it to its original location. Whereas in cervical elongation, I'll be doing something called as Manchester Fothergill repair, wherein I'm going to be amputing the cervix and making it back to its original length. So basically, I'm cutting the cervix off to make it back to its original length. So talking about the sling surgeries first, we have several sling surgeries. Those several sling surgeries include the commonest one that is done, that is Purandare cervicopexy. Next, we have Shirodkar sling. Then we have Virkud sling, or what we also call as a Virkud's composite sling. And we have Khanna sling. There are also procedures like Joshi sling that we don't do at all today. These are the four more important sling surgeries. These sling surgeries are divided on the basis of a few points. So those few points are, is it anterior sling or is it a posterior sling? Secondly, is it an open or a closed sling? And lastly, is it a static or a dynamic sling? Every single sling is going to be divided on the basis of that. So now first talking about Purandare sling, Dr. Purandare, he said that the uterus is going down. What I'll do is I'll just pull it up and I'll attach it anteriorly. So if this was my cross section of the pelvis and this was my uterus, he said that I'll take a tape, a Marcelin tape, and I'll attach it anteriorly like this. And over here on the isthmus of the uterus, the isthmus is the part between the uterus and cervix, I'll suture it there with a non-absorbable suture. And the tape that was used was Marcelin tape. This was called as Purandare cervicopexy because it was being attached to a level near the cervix on the isthmus. So this was called as Purandare cervicopexy, but there was a problem. I have mentioned that our normal uterus has this angulation. Now, if I'm going to attach this tape and going to attach it anteriorly, I'm pulling this uterus anterior. What was this doing is, this was making the angle of the uterus retroverted. So it was making it retroverted. What is retroversion? It was making it like this. Why? Because the sling was pulling it anteriorly. What this did was, the Denon-Villiers fascia that was there posteriorly got pulled and it sustained tears. Now, because of those tears, this female started having rectocele. Also, because this got too close to the bladder anteriorly, it also led to cystocele. So cystocele and rectocele started increasing because the bladder got too close and the posterior Denon-Villiers fascia also got torn because the vagina was pulled anteriorly. Also, retroversion is not great for fertility because the normal tract of the sperms is going to be made poor, which is why the chances of this female conceiving were also reduced, and this surgery is in fact being done to conserve the uterus, and that was not happening, and hence Purandare's cervicopexy had this big problem of this being an anterior sling. This problem was solved by Purandare himself. He said that there are two ligaments that are present over here called as the round ligaments. So what he decided was, ये जो round ligaments है, उसको मैं plicate करूंगा with a suture material. Plication is basically reducing the length. So when the length of this was reduced, the uterus or the fundus rather got pulled anteriorly again, and the angle of anteversion was corrected. Why? Because the length of the round ligament was reduced using sutures, and hence this surgery of Purandare cervicopexy is combined with round ligament plication. Is always done with round ligament plication. And this is the entire procedure that is done. It is never done without a round ligament plication. So to determine what was the type of this surgery, Purandare cervicopexy was an anterior sling. It was a closed sling because it was forming a closed loop anteriorly. Anteriorly, this was being attached to the rectus sheath, by the way. So it was a closed loop, and it was a dynamic sling. Why dynamic? Because every time a person coughed or sneezed, the anterior abdominal wall would get pulled out, and that would pull the rectus sheath ahead, and this sling would also get pulled out. So basically, it was a dynamic sling. It was a mobile sling. It was a slightly less stable one. I've already mentioned that excessive mobility is not a good thing for the pelvic organs, and hence this was a anterior closed dynamic sling. But there was one problem. The problem was that I'm doing the surgery to preserve the fertility, and once this surgery is done, I do not want a vaginal trial of labor to worsen the sling surgery outcome. So once a female conceived, the only way of preventing a prolapse again was by doing a cesarean section. But when I'm doing a cesarean section, it is my isthmus that actually becomes the lower uterine segment. And once it becomes a lower uterine segment, it is the place where I'm going to be taking my lower uterine incision or the curve incision during cesarean section. And when I was taking this incision, that tape would get torn off. And once the tape was torn, that would lead to failure of this surgery in itself because the tape was now lying open. So Purandare cervicopexy would fail during a cesarean section. So Dr. Praveen Mhatre suggested a change in it. He said that a modification can be done wherein if this is my pelvis and if this is my uterus, what I'll do is instead of anterior, I'll just put this posteriorly like this, and I would tie it posteriorly. This was called as the Mhatre's modification of Purandare sling surgery. Not many people know about this, but it's a good thing if you know it, Mhatre's modification. But the problem again was that it was an anterior sling, it was a dynamic sling, it would keep moving, and with age, as the abdominal tone reduced or after delivery, when the anterior abdominal tone anyway goes away, and in India, the women don't even do anything to work on their tone, that was leading to a failure, and several years after the surgery, the prolapse would again come back. That is when Dr. Shirodkar came in and he said that the problem is with the dynamic nature of this sling. So what I'll do it, I'll make it a static sling. How do I make it static? He said, I'll attach the same uterus to an organ that is not so mobile, and that happened to be my sacrum. So he said, I will attach this posteriorly to the sacrum, but he also knew that if I'm going to attach a foreign body, a Marcelin tape to the sacrum, to the periosteum, that can lead to periosteitis. So he said, I'm not going to attach it to the bone per se, I'll attach it to a ligament that is present over here, a fibrous ligament called as the anterior longitudinal ligament. He said, I'll attach this over here. So this turned out to be a very good surgery. First of all, it was a posterior sling. Secondly, it was again closed and it was a static one. A very good one. And this could have been the procedure of choice, but there were two problems. The first problem was that posteriorly, I had my bowel loops over here. Bowel loops could get trapped inside and that could lead to strangulation and that could lead to immediate death. That was one of the complications. Secondly, posteriorly, I have to go through a region wherein as a gynecologist, I'm not that comfortable. It includes going near the psoas muscle, near the ureters, and even near the sigmoid colon on one side. Basically, on my left side, there is going to be sigmoid colon as well. It was a very dangerous surgery that I, as an obstetrician, was not really comfortable with it. Here, it was a psoas muscle that I had to go through. I was not really comfortable, which is why this surgery really never gained that much of prominence. It is done by many people, but Purandar is the preferred one because of its ease of operation. But the facts state that it was a superior surgery to Purandare. So Dr. Virkud said, why not combine the good things from both the surgeries and make a sling surgery of my own? The name of it was going to be, this was Shirodkar's sling surgery. Dr. Virkud said, let me make a composite sling. Composite is basically a combination sling. He said, I will combine the good parts of both of them. So if this was my pelvis, if this was my uterus, he said that posteriorly, I will take the sling on one side and I will attach it posteriorly like this. And the other side is going to go and attach anteriorly. So now this is an open sling. So the risk of strangulation is gone. It is a dynamic plus static sling because this part is static, this is dynamic. So basically it is lying open. It is having the advantage of being static as well. One end of it is going to be adhered completely to the bone because the bone doesn't move. And it is an anterior plus posterior sling. So it is not just completely going posteriorly. Plus I'm going to avoid the sigmoid colon that was present over here. So the sigmoid colon damage, bowel damage was also reduced. This happened to be Virkud's composite sling surgery. So Virkud's composite sling surgery was anterior plus posterior. It was an open loop and it was static plus dynamic. A good surgery, a very good surgery if you can do it. The last one was Khanna sling surgery. He said going posteriorly is a problem for gynecologists because they are not comfortable with bowel. Anteriorly, it is causing a problem of the sling being dynamic. So what I'll do it, I'll find a point that is anterior and is also static. So the point that he found was, if this was my thing, he said I'll attach it like this to a point called as the anterior superior iliac spine. Anterior superior iliac spine, this was called as a Khanna sling surgery. So it was an anterior sling, it was a closed loop, and it was also a static one. But you never hear of a Khanna sling being done. Why? Because the problem was posteriorly I had something called as an anterior longitudinal ligament. So the bone was spared of a foreign tissue called the Mercellin tape. But here there was directly the bone. I had to attach this tape to the periosteum. And the periosteum of ASIS is easily near the skin. You can easily feel it on yourself as well. And hence that would lead to erosion of the skin and periostitis as well as ulcers. And hence this sling never gained that prominence. This was the shortcoming of Khanna's sling surgery. And these were the sling surgeries that none of your books have it in them. None of the books, PG books, have given these surgeries. The UG books, the Indian authors have given it. Unfortunately, the foreign authors do not recognize these surgeries or they just don't give any prominence to it. But you have to remember that these are very important sling surgeries. None of the books mention, but you as an Indian have to be proud that our Indians have contributed a lot to young females with prolapse, especially because India is a country where many young women get pregnant and they eventually face these problems around the age of 30, 32, wherein they say that I still need to have a kid and I need to conserve my uterus. A very good surgery, sling surgery. Now coming to the other side of it, the other side was, what if there is cervical elongation? So in cervical elongation, we have a surgery called as, by the way, I'll just show you the anterior longitudinal ligament. I have taken a picture of it. Yeah, over here. So yeah, if you can see, there is this anterior longitudinal ligament over here. You see, this is the anterior longitudinal ligament on which we would attach the sling of the Shirodkar's surgery over here. Anyway, so now coming to the next surgery that happens to be my Manchester Fothergill repair. This is the Manchester Fothergill repair. In this, Manchester is the place in England where it was done first. Fothergill was a surgeon who did it. It was a stitch that was taken. Later on, there is one more stitch that was introduced, that is Tombed-off stitch. There is a separate lecture that I've taken. There's a separate video on conceptual that I've taken on the each and every detailed video of this surgery. So what we do in this surgery is, first of all, you see that the cervix is elongated. The cervix has come out. What I have done first of all in the first step is that I have separated this cervical mucosa from the rest of this mucosa. So basically I have separated it completely. Then you can see that these two ligaments that are seen over here, black color in the second picture, these are the uterosacral ligaments. So I have separated the uterosacral ligaments in this picture. You can see that in this picture I am cutting the uterosacral ligaments. Those uterosacral ligaments are divided, they are separated from the cervix, then they are kept long on threads. You can see these threads that are put on them. These are called as stay sutures. Stay sutures are sutures that are kept to hold them. After that, I'm going to cut the cervix. You see that the cervix is being cut in this location. Once this cervix has been cut off, this is my new cut off cervix, or what we also call as the neo cervix. On it, I'm going to reattach these two. You see these threads? I've reattached it. I've reattached the uterosacral ligaments on the new cervix, and then I've used the posterior vaginal wall to cover up the new cervix. This covering is also called as the Sturm-Dorf stitch. Whereas the reapplication of the uterosacral ligaments back to the cervix is called as the Fothergill stitch. What this did was the uterosacral ligament that was lying lower was separated and it was attached to the higher level. So it pulled the uterus a little upwards, and I also cut the cervix. So the cervical length was also reduced. So this surgery effectively not just cut the cervix and corrected the cervical elongation, but it also pulled the uterus slightly higher up because of refixation of the uterosacral ligaments. And hence, Manchester Fothergill repair is an excellent surgery that women who are wanting to have the pregnancy in future but have cervical elongation is going to work for them. The shortcoming is that whenever I'm amputing the cervix, I'm cutting the cervix off, I'm taking away several smooth muscles and collagen from her cervix. When I'm taking off much of this, remember that the female during a subsequent pregnancy will not be able to have good dilatation of the cervix because the smooth muscles are gone. She also will not have good effacement because the collagen is gone. It won't be able to become thin, which is why these women have to be delivered by cesarean section because they will have cervical dystocia. Cervical dystocia is the cervix doesn't dilate, and hence they have to be delivered by cesarean section in the subsequent pregnancy. So Manchester Fothergill repair for females who want to conserve their uterus. What if I want to do something else? I'm not good enough with sling surgeries. I'm not good enough with Manchester Fothergill repair. Is there any other method? Yes, there is a surgery. There are a group of surgeries called as the hysteropexies. You can see over here, this is a hysteropexy. What do I do in a hysteropexy? This is my uterosacral ligament. I just remove this uterosacral ligament, I cut it off and I reattach it at a higher level. So my uterus is conserved. The uterosacral ligament which had gone below and had become loose was cut off. I removed this much part of it. I shortened the length of my uterocervical ligament and then I reapplied it at a higher level. This is called as uterosacral hysteropexy. Hystero is uterus, pexy is repair. Uterosacral is using the uterosacral ligament itself to pull it up. The problem with this surgery and why it is not done is that the problem in first place was that the endopelvic tissues and the endopelvic fascia, including the uterocervical ligaments, had gone weak. So merely by reducing the length of the uterosacral ligament is not going to help the uterus much. In fact, you are increasing the stress on them and eventually they are going to tear and the prolapse is going to recur after a certain period of time. So this surgery has a high failure rate and hence uterosacral hysteropexy is no longer done. It is a part of theoretical things but no longer done. We prefer to use a Mercilin tape to do the sling procedure. The point of that sling procedure is itself to replace the uterosacral ligament, the function that the uterosacral ligament was doing of keeping the uterus pulled up. These were the surgeries of for patients in whom you want to conserve the uterus. What about the other side of the spectrum? The other side of the spectrum wherein a female doesn't want to conserve her uterus. So the next side is uterus non-preservation surgeries. Now remember, all these surgeries that we are talking about are for uterine prolapse. And when I say uterine prolapse, it means that I'm talking about apical compartment only. I talk about posterior and anterior compartment. At the end, it is very simple. Currently, we are talking about apical compartment failure. So in women who do not want their uterus and also having prolapse, I have to do two things. The first is I have to do a hysterectomy. And once the hysterectomy is done, I have to ensure that this was my uterus and this was my vaginal vault. I have now removed the uterus. So my uterus is now removed completely. And what I'm left with is my vagina only. Earlier, this uterus was attached by uterosacral ligaments and kept in place. But now that I've removed the uterus, if I don't reapply these uterosacral ligaments back to this vaginal vault that is kept inside, this vaginal vault will fall out, also called as the vault or vaginal vault prolapse. Because vagina is going to be a free floating organ if I'm not going to provide it with support. So what are the supports that I can give? So I have to combine hysterectomy with vaginal vault suspension. So there are two ways I can suspend it. One is with the uterosacral ligament itself, which is how it was earlier, or the second one is with the iliococcygeal ligament. What is going to be my preference? If this is my pubic symphysis and this was my sacrum, my uterosacral ligaments were at this level. Whereas my iliococcygeal is going to be at this level. It is a part of the levatorinae. So if I'm going to keep my vagina, which is supposed to be this way, the natural direction is towards my uterosacrals. So uterosacral suspension is going to be much more natural. Instead, if I do iliococcygeal suspension, the problem that I'm going to face is going to be that my vagina is going to get directed too posteriorly like this. And also because of this pulling, it is also going to reduce the length of the vagina. Remember that the length of vagina should be preserved because vagina after hysterectomy, let's say you have done a hysterectomy in a 50-year-old female, she still can have and will want to have coitus. So for preserving her coital potential, you cannot be reducing the size of the vagina, nor can you make it too posterior. Because if you're making it too posterior, your bladder, which was there anteriorly, and the endopelvic connective tissue that was there between this, it is going to start getting torn because you have separated the vagina and made it too posterior. And also your rectum is going to come too close to it. So you are again going to, just like Purandare cervicopexy, you are going to have cystocele and rectocele, which is why iliococcygeal surgeries are not preferred. The surgery that we commonly do is uterosacral vault suspension. So how does this surgery look like? I have kept a picture of uterosacral. Yes. So over here, you can see that this is my vaginal vault. This happens to be my vaginal vault, and this is my uterosacral ligament. I will probably use another color. Yeah, this is my uterosacral ligament over here. You see that after I'm done with my hysterectomy, this is a superior view. You can see that my uterosacral ligament is blue color over here. You see this? This is my vaginal vault below, and this is my uterosacral ligament, and this was my vaginal vault over here. So I have attached it on both ends. What this also does is it keeps my vagina in the center. It is not pulling it on either one side or the other side. It is keeping it in the center. It is pulling it towards its original direction that was directed posteriorly. The iliococcygeal ligament would have been here. It would have made it too short and posterior. I do not want that. And hence uterosacral ligament fixation is going to help me significantly in conserving the normal direction of the vagina. This is called as uterosacral vault suspension. But as I've mentioned that this uterosacral ligament is made up of endopelvic fascia condensation. And endopelvic fascia gets thin because of estrogen deficiency after menopause. So if it's an 80-year-old female who has a very thin endopelvic connective tissue and very thin uterosacral ligament, in that scenario, I cannot suspend it with a uterosacral ligament because it would be very thin and there's going to be a recurrence. In that scenario, I have to find something where I can suspend the vaginal wall and also ensure that it doesn't recur. Now remember, this is going to occur more so in a female who's 70, 80-year-old in whom the coital potential is not there. She's never going to have coitus again. So I can afford to lose the direction of the vagina. So in that case, the surgery that I do is called as the walled prolapse surgery or surgery of sacrospinous fixation. So in my pelvis, these are my sacrospinous ligaments. Sorry, I've marked them over here. Mark it this way, yes. These are my sacrospinous ligaments over here. Now, these sacrospinous ligaments are proper structures which are not going to go with my estrogen deficiency, with my menopause. These are not going to get thinned out. So what I do is I pull it and I attach it to one side, which happens to be my right side. This right-sided sacrospinous fixation has been done over here. This is, you can see over here, this is going to deviate the vagina towards the right side and is also going to make it too posterior, but I don't really fear about it because the coital potential is not there. Why do I need to do this? Because on the left side, I have my sigmoid colon, and this sigmoid colon can get injured while trying to access this sacrospinous ligament. And hence, a sacrospinous fixation is only done towards one side, and that is your right side. You can do it on both sides, but there is a risk of perforating a sigmoid colon, and hence it is not preferred. Hence, sacrospinous fixation of your vaginal vault is going to be done only on the right side. This is a procedure that can also be done for vault prolapse, a female who has had hysterectomy and has come back to me after a few years with vault prolapse, and can also be done in very elderly women. But the problem is that this is a very difficult ligament to reach, and there can be risk of injury to vessels as well as nerves. And what if this female happens to be a young female who has extremely thin uterosacral ligaments in whom I cannot afford to deviate the vagina because she still has coital potential? In that scenario, I use a mesh and I do a surgery called as sacral colpopexy. Colpo is vagina, pexy is repair. I attach the vaginal wall, which you can see over here, to the sacrum, to the anterior longitudinal ligament using a mesh. You see, this is a mesh that I have used. This is a mesh that I have used. This is called as sacrocolpopexy. This is also ensuring that my direction of the vagina is maintained. Now remember that FDA has said that mesh is not really great an option to be used in prolapse surgeries. You can still use it in TOT and TVT for SUI, but you should preferably avoid using it in prolapse surgeries because of its complications. But this is one of the places where you can do it. This is done more so laparoscopically. This is called as sacral colpopexy, wherein the colpos, that is my vagina, is being suspended with my sacrum using a mesh in between it. We make a Y-shaped mesh so that this is how it is going to look like. This Y-shaped, this part goes to the sacrum, this part goes to the vagina, and in between this, you have your bowel loops that can go down. So this Y-shaped is called as sacral colpopexy. Now coming back to other types of prolapse, and that happens to be my other apical form of prolapse, which is enterocele. So when I talk about enterocele, in enterocele, I can repair it abdominally or I can repair it vaginally. Now the problem was, this was my pubic symphysis, this was my sacrum, this was my uterus, this was my rectum. The problem here was this pouch of Douglas that was coming down significantly because my endopelvic fascia had become thin over here. So what I can do is, I can just obliterate it at a higher level. I can take sutures at this level so that this space gets obliterated, this peritoneal fold gets obliterated. These sutures can be taken abdominally or they can be taken vaginally. So if this was my pouch of Douglas and if I'm taking a single layer of stitch abdominally, this is called as Moskowitz repair. It is basically a purse string suture that I'm taking and I'm obliterating the space completely so that this lower part is completely obliterated and the bowel which was coming down inside this now cannot go beyond this like this. So Moskowitz repair is done if it is done abdominally and a single stitch is taken. If multiple layers of stitches are taken, we call it Helben's repair. Similarly, if you are doing the same thing through the vagina, we call it McCall's culdoplasty. Why culdoplasty? Because you call it cul-de-sac. The other name for pouch of Douglas is cul-de-sac. So culdoplasty is repairing the cul-de-sac, wherein you do the same thing but vaginally. You can do it in multiple sutures or a single rim. You prefer to do it to multiple so that the risk of failure and recurrence is less. But if you do it vaginally, it is going to be called as McCall's culdoplasty. So to repair the enterocele, all I have to do is I have to obliterate the pouch of Douglas to prevent the bowel loop from coming down. And the last part of my session happens to be my anterior and posterior compartment failure. So if my anterior and posterior compartment has failed, what is the problem that is happening? The bladder that was there, this was my bladder, this was my uterus, and this was my bladder. The endopelvic fascia between them, which used to be so much earlier, because of menopause and parity, everything, this bladder has become too close to my uterus. And the endopelvic fascia over here has thinned out. So to show it to you in a pictorial form, this. If you can see this pictorial form, you can see that this white tissue is actually this endopelvic fascia. And you can see that this has become too thin. You can see that there are these black defects that you can see over here. These black defects. These black defects are basically the deficient endopelvic fascia. So what I'll do is, first of all, this is the extra anterior vaginal wall, which because of the bulging had become excessive because of stretching. So I'll cut it first. I'll cut it like this. After that, I'll separate this endopelvic fascia, and then from both the sides, I will bring it in the center. You see, जो भी बचा कुचा ऐसा बाजू में गया था, whatever had gone laterally because this bladder had come through it, I will bring that endopelvic fascia again over here. I'll take stitches over here so that the bladder is again pushed away, and these stitches are going to be taken over here anteriorly. These stitches are basically accumulating whatever endopelvic fascia was remaining, and that now you can see first it was completely deficient over here, but now you can see that this has become much more uniform and the endopelvic fascia has been brought to the center and it has been stitched. This is called as anterior colporrhaphy. Colpo is vagina, anterior is anterior. Anterior vaginal repair is called as anterior colporrhaphy. But if it's a very elderly female who doesn't have endopelvic fascia left at all, in that scenario, what you can do, you can put in a synthetic tissue called as a mesh. It is not allowed, but that is an option. You can put a mesh. That mesh is going to have pores inside it. These pores are going to help all the fibroblasts come in. The fibroblasts are going to come in and they are going to cause fibrosis. And this fibrosis will eventually cause a tissue and a layer between the bladder and the uterus. A false layer between the bladder and the uterus is going to be formed. That is going to be mesh based anterior colporrhaphy. It is not recommended though because of mesh related complications. But this is anterior colporrhaphy. You do the same thing posteriorly. It is going to be called as posterior colporrhaphy. And the end of it, assume you have a 90-year-old female with you who has a prolapse, but she is also known case of heart disease, hypertension, diabetes mellitus, and who may not probably tolerate all these supra major or major procedures wherein you are removing an organ in complete sense. She may collapse, she may have excessive blood loss, which her heart will not be able to sustain. In that scenario, you have one surgery, that is, you just close the vagina. You close the vaginal vault and you push the uterus that had fallen out inside it again. This is called as colpoclysis. Colpo is vagina, clysis is closing down. Vaginal colpoclysis or Leffort's colpoclysis. Leffort's colpoclysis is a surgery in which you are going to completely shut down the vaginal vault and push it inside. I do not have a picture of it right now, but in it, what you do is the vagina which has come out, you cut two layers of vagina from the anterior cervix and the posterior cervix. Then you join them, and when you join them, the uterus gets pushed inside completely, and the vaginal vault also closes down, it narrows down. There's a small hole that is left in the vaginal introitus for the secretions of the cervical glands to flow out whenever they have to. But that is it. That is called as Leffort's colpoclysis. And with that, we finish a session on pelvic organ prolapse. An exhaustive session, but we have spoken about all the possible surgeries, the mesh surgeries, the conservative surgeries, every single thing. If you all have any doubts, do let us know. Keep watching Conceptual. We also have the king of urogynecology, Dr. JB Sharma, on board, and he has taken lectures on each and every urogynecology topic. So I would urge you all to subscribe to Conceptual OBG and watch those videos by the master, by the king himself. This is Dr. Aditya signing off. If you all have any doubts, do reach out to our team or reach out to me directly. I'll be more than happy to answer them. This is Dr. Aditya signing off. I'll keep seeing you again on Conceptual OBG.